Thank you, sir, for your kind introduction. Respected Chairperson, dear audience, Assalamu alaikum and a very good morning to you all. I am Dr. Tasneem Hossain from National Institute of Cancer Research and Hospital, going to present my work on efficacy of radiotherapy for ovarian ablation in metastatic breast cancer, comparison between 15 gray in 5 fractions and 20 gray in 10 fractions. Breast cancer is the most common cancer worldwide and fourth leading cause of cancer death according to Globocan 2020. It ranks first among Bangladeshi women. The incidence rate is 17 and mortality rate 9.3 per 1 lakh of population. Of this tremendous case burden, a good portion of them are premenopausal, and as high as 60% are hormone receptor positive. Among the metastatic burden, only 10% are de novo metastatic and rest progress on to become metastatic. The aim of treatment in such are control of tumor burden and improvement of quality of life. As we all know, hormone receptor positive metastatic breast cancer patients who have no visceral crisis are candidates for hormonal therapy. The history of hormonal manipulation dates back to 1896 when Dr. George Beatson first discovered the benefit of oophorectomy in breast cancer patients. Along came radiation-induced ovarian ablation and medical ovarian suppression by LHRH analogs. Another fourth form of chemo-induced ovarian suppression is also there. The rationality of this study lies in the following facts. A large metastatic case burden is observed in Bangladesh due to lack of awareness, ignorance, and low socioeconomic condition, high investigation cost, and lack of specialty centers. For premenopausal hormone-sensitive metastatic patients, radiation-induced ovarian ablation is reasonable, cost-effective, non-invasive, patient-compliant procedure. A range of 10 to 20 gray has been historically used over the years in search for the optimum yet efficacious fractionation schedule. We compare the conventionally fractionated 20 gray 10 fractions over 2 weeks with 15 gray 5 fraction over a week schedule, as it reduces hospital visit cost and also machine occupancy. In order to compare between two fractionations, we aim to compare the efficacy in terms of development and persistence of amenorrhea for consecutive 3 months and or attainment of postmenopausal level of FSH and estradiol 6 months post-radiation, development of acute radiation toxicities according to CTCAE grade, and postmenopausal symptoms according to menopause rating scale. This was designed as a quasi-experimental study which took place at the Department of Radiation Oncology, National Institute of Cancer Research and Hospital. Purposive sampling technique was used, and it was carried from 1st March 2024 to 31st August 2024. Diagnosed cases of hormone receptor positive, HER2 negative metastatic breast cancer who were premenopausal women having regular menstrual period or who have had normal menstrual period within 12 months having premenopausal level of serum FSH and estradiol were included in the study. Any known gynecological pathology or who desired future pregnancy, patients in visceral crisis, prior pelvic radiotherapy, or prior chemotherapy within last 1 year were excluded from the study. The selected patients were divided equally in 2 arms, and response was evaluated at the end of 6th, 12th, 24th weeks after radiation. The final analysis was done. Let's look at the radiation planning very briefly. 2D simulation was used. The inferior border taken at mid-obturator plane, lateral border 1.5 centimeter lateral to true pelvic brim, superiorly at lower border of L5. When we looked at the results after analysis, most patients in both arms belong to 36 to 40 years of age. Most of them had metastasis on progression, while bone-only metastasis was most common in 2 arms. Only a few had visceral metastasis. Majority had invasive ductal cell carcinoma grade 2, and when receptor analysis was done, mostly they were found to have both estrogen and progesterone receptor positive. The risk factors were analyzed, and most common risk factors were the use of oral contraceptive pills and early age at menarche. About 30% of patients were found to be overweight, and a few obese in both arms. So in terms of baseline characteristics, there was no statistically significant difference between the two arms. Previous treatment history was analyzed, and most patients in both arms received previous chemotherapy, but none within last 1 year of the study, and around 60% patients received previous hormone therapy. Now let's look at the response in both arms. Time of amenorrhea development was recorded. Only 8.8% patients in arm A and 5.8% patients in arm B failed to develop amenorrhea. The same patients did not attain postmenopausal estradiol level, that is less than 30 picogram per ml. In addition, 7 patients that is 20% in arm A and 4 patients, that is 11% in arm B, failed to attain the postmenopausal FSH level, which was said to be more than 22 milli-international unit per ml. Analysis of the hormonal levels in both arms revealed that there was no statistically significant difference in terms of mean hormonal value when measured at baseline at 6th, 12th, 24 weeks, but a significant rise and fall of serum FSH and estradiol respectively was observed when compared with baseline at the end of 24th week. Further investigation was conducted in search of factors responsible for failure to achieve response to radiotherapy. A significant positive association was found with baseline high estradiol value and failure to attain a response in estradiol level. The mean was 116 picogram per ml. Also, a positive association was discovered with overweight and obesity with failure to develop amenorrhea. Again, a significant positive association was observed with previous chemotherapy in regard to failure to develop postmenopausal FSH and estradiol values. Age of patient was significantly associated with failure to develop amenorrhea, all patients being in the age group of 26 to 35 years of age. Radiation-induced toxicities were analyzed according to the CTCAE version 5. No grade 3 or 4 toxicities were observed, and most commonly occurring toxicities were nausea, abdominal pain, etc., without any significant difference between the two arms. Postmenopausal symptoms were analyzed according to the menopause rating scale in respect of 11 symptoms. Most common symptoms were hot flush, irritability, insomnia, etc. So after thorough observation and analysis of 1 year, we concluded that there is no difference in efficacy of radiotherapy between 15 gray in 5 fractions and 20 gray in 10 fractions in premenopausal hormone receptor positive metastatic breast cancer patients. However, several factors were found to be responsible in failure to achieve successful ablation, namely young age, prior absence of chemotherapy, high BMI, baseline high estradiol values. These were the key references used in the study. I acknowledge all involved in my work for thorough guidance and help. Thank you all for patience hearing, and thank you for giving us the platform.